My job is to talk a little bit about abnormalities that occur in the shoulder of throwing athletes. And I would make one comment about it. Most of what I'm going to say is going to relate to baseball pitching, because certainly the mechanics of a variety of sports that involve throwing things differs in terms of arm position and arm movement. But most of the articles that have addressed this particular topic have stressed baseball pitchers and baseball pitching, and that's what I am going to do. We're going to go over some anatomy. We'll talk a bit about pathophysiology. I'm going to introduce some concepts and controversies regarding those concepts. We'll emphasize MR imaging throughout. I wanted to start with these images because they're images that I obtained probably 15 years ago of one particular baseball player. At that time, he was a future Hall of Famer. He's now in the Hall of Fame. He was a baseball pitcher, and I just wanted to show you toward the end of his career what his shoulder looked like, what his elbow looked like on the dominant side. So clearly, there is a lot of trauma and stress involved in baseball pitching, particularly if you're lucky enough to reach the major leagues. If you go into the literature and try to come up with a description of the various stages or phases of baseball pitching, you won't always get the same list that I'm providing you on this particular slide. In this slide, these are the classic stages. So we will talk a bit about cocking phase, acceleration phase, deceleration phase, and follow-through phase. And it's of interest as you look at this, and I'll run through, Christine gave me these images. They go fast, but so does the baseball with most of the current professional baseball pitchers. This is what it looks like in the various phases of throwing. With each of these phases, different muscles are activated, others are relaxed, and so there's a lot of action going on, and it varies from one phase to the other. Now, although there's a debate about which particular phase of pitching might be the worst for the shoulder, most of the articles, I think, and the ones that I respected and learned the most from, would suggest it's towards the end. It relates to the deceleration and follow-through phases when a lot of motion.
Good morning. We're going to have a look at fractures and dislocations of the upper extremity and the role of CT scanning. So I have nothing to disclose. The objective of the talk is to show many varied cases of upper extremity trauma, have an emphasis on CT and 3D reconstructions, and enable the viewer to determine when 3D reformatted images are useful. If you want to order these, you can just write in the request that you want 3D reformats, or you can use the CPT code 76377, which will get you an interpretation of the 3D images. And if you're interested, we have 2 full-time 3D technologists at the moment in the radiology department. So there's somebody on site from 7 a.m. to 11:30 p.m. available for 3D imaging. You can also do this yourself. And so here's a screen capture. And all you have to do is to click on the colorful cube, and up will come a box. And basically the ones you want to select, the series you want to select, are the soft tissue algorithm in the original plane with the greatest number of slices. So if we start at the sternoclavicular joint and work our way to the hand, at the sternoclavicular joint, dislocation is rare. It can be acute or chronic. It can be subluxation or luxation, and it can be anterior or posterior. So starting with anterior, this has few long-term problems. You can make an attempt at a closed reduction, which is recommended, usually with a bolster between the shoulder blades and 2 people pulling in opposite directions. Posterior dislocation has greater consequences. If you look here at this 15-year-old male, you can see that the medial ends of the clavicles are at slightly different heights. Now, it's either going to be that the left side is elevated or the right side is depressed, and we're interested in the right shoulder, which is presumably symptomatic. And the one, if the affected side, if it's inferior, it will be a posterior dislocation. If it's superior, it will be an anterior dislocation. So this should be a posterior dislocation of the medial right clavicle, with the corresponding CT images showing exactly that, with the medial end of the clavicle in the mediastinum. So these posterior sternoclavicular joint dislocations are less frequent than anterior, but the consequences are far greater. Usually we can still have closed reduction. If open reduction is required, also often there'll be a reconstruction of the capsule. And there's few long-term problems. So as we look at this 18-year-old, we can see the clavicle fracture on the right, and then we can see the deviation of the medial end of the right clavicle into the mediastinum.
Hello everybody, my name is Brady Huang. I'll be spending the next 45 minutes talking to you about the flexor and extensor tendons of the wrist. I'm going to divide this discussion into two parts. We'll first talk about the dorsal aspect of the wrist, the extensor compartments and extensor retinaculum, followed by the volar aspect of the wrist, the flexor tendons, or carpal tunnel, and the various spaces that exist along the volar aspect of the wrist. It's important to recognize the anatomy at the dorsal aspect of the wrist, and more specifically the extensor retinaculum, which is a distinct thickening of the antebrachial fascia. That's the fascia that encircles the entire forearm. And this distinct thickening, as can be seen here on the sagittal cadaveric section, is what helps keep the extensor tendons closely applied to the dorsal aspect of the wrist, giving them a mechanical advantage during wrist and finger extension. Likewise, we can see here on a sagittal corresponding MR image, you can see its relationship, its fusiform nature, with the underlying extensor tendons. Here a cadaveric cross-sectional image also showing the extensor retinaculum nicely, the fibrous white tissue representing the collagen fibers, and you can actually see that there are portions of the extensor retinaculum which are formed deep to the extensor compartments. These are referred to as the infratendinous retinaculum, whereas the more superficial components are referred to as the supratendinous retinaculum. And one more thing that you may observe on this image is that this extensor retinaculum is in fact continuous with the flexor retinaculum of the wrist, again being a distinct thickening of the antebrachial fascia of the forearm. Likewise, you can see this on MR imaging, the corresponding MR image in this cadaver, and you can see particularly over the fourth dorsal extensor compartment that this extensor retinaculum is very well formed, where it measures up to 1 to 2 millimeters in thickness. Now, the extensor retinaculum does have several osseous attachments. They're referred to as the septal attachments that help separate the extensor tendons into their various compartments. So as we go from radial to ulnar, there are 6 distinct dorsal extensor compartments, starting with compartment 1, abductor pollicis longus, extensor pollicis brevis, compartment 2, extensor carpi radialis longus and brevis, and then we'll pass over this bony landmark or hump referred to as Lister's tubercle. This is an important landmark. We'll find the third dorsal extensor compartment, or extensor pollicis longus. Next to that, we'll find the fourth dorsal extensor compartment, extensor digitorum communis and extensor indicis proprius. Next to that, the extensor digiti minimi. And finally, in the ulnar groove, the sixth extensor compartment, or the extensor carpi ulnaris tendon. And if you're trying to remember these tendons and keep them straight in your head, at least the first 3 compartments, you can use the mnemonic longus, brevis, longus, brevis, longus.